Hello everyone. So today we are going to continue by talking about drowning. So I want us to know that drowning is a state of respiratory impairment or a sensation of respiratory distress that occurs following submersion into water. Right? We are already familiar, with cases of drowning and the pathophysiology of the damage that occurs with drowning occurs in phases. So the first thing is when somebody gets drowned, there is a panic. There is more like a physical agitation. And following that, there is a breath holding spell. So the person doesn't want to breathe. So that person will not aspirate, right? So they hold their breath, causing hypoxia. The remaining oxygen in the body at that time is going to be used up by the metabolizing tissue, and they are going to generate a lot of CO2. Don't forget the effect of hypercapnia on the breathing reflex. So, because of the hypercapnia, from the breath holding, there's activation of the breathing reflex. So the body tries to breathe to take out the CO2 and take in oxygen. So when this happens, the person immediately tries to breathe and in the process aspirate the water into the lungs and also swallow water through the esophagus down to the stomach. Now, this aspiration is going to further worsen the hypoxia, leading to hypoxemia. The body organs start suffering from this. And the two major organs we need to focus on is the brain and the CVS, the heart and the brain, the heart and the brain. So what happens? Hypoxic insult to the brain can cause seizures, right? It can cause drowsiness, stupor state, altered sensorium generally. They can lose consciousness. To the heart, it can cause some deadly arrhythmias. It can cause cardiac arrest. It can even cause heart failure. When there is cardiac arrest, the heart is no longer functioning as it should be. There's hypoperfusion leading to hypotension. Don't forget, most of the time they are immersed in very cold water body. So bring about hypothermia. So you want to check for hypotension. It's part of what you are going to see in them because of the cardiac problems. They are immersed in cold water. They are going to have hypothermia. Of course, they are not getting enough oxygen, either from the breath holding or from the aspiration, leading to reduced oxygen delivery into the body, causing hypoxemia. Anybody that have an experience of drowning, you must wear cervical collar for them when it's available. You know, immobilize the cervical spine, especially in the people that get drowned in very shallow water body, because there's a very high risk of injury to the head and to the neck because of the shallow water. So you have to immobilize them with a cervical collar until you do your imaging to rule out any problems with the structure. So how do you proceed? Your diagnosis, your treatment. What the first thing I'm going to mention is that you have to ensure that you protect yourself and not harm yourself while you are trying to rescue a casualty. That's the first thing. The second thing is you pull out the patient, from the water into a dry, flat surface. You expose, remove the wet clothing. Then you start with your primary survey. So, which is talking about your ABCD generally, right? Your ABCD, your airway. You want to check the airway. Is this patient is the airway patent? If it's not patent, you might want to do some maneuvers at that time, right? To to open the airway, you want to do your chin lift, your jaw thrust, and you want to deliver your rescue breath. Particularly if you go to the B and the patient is not breathing, right? You want to do your rescue breath. You check for the C, which is your pulse. Is the patient having a pulse? Not having a pulse. Of course, before you even start your ABCD, you will have called for help. So they are already coming, call your 911. They are coming to your position with the defibrillator. So, but prior to the time you are waiting, you are delivering your rescue breath and you have started your cardiopulmonary resuscitation. So you are doing your 30 chest compression and your 2 rescue breath delivery, right? Um, Once the defibrillator comes in, you clean the body, you attach the plugs, you assess the reading with shockable or not. So I'm not going to go deep into that because my chief is going to elaborate on that. Dr. Brian Day is going to, you know, explain that elaborately, in an elaborate manner to us. Um, so, you assess the reading, shockable, non-shockable. If it's shockable, you deliver a shock. You continue your CPR. If you don't have, restoration of normal cardiac function, and if it's not shockable, you can give epinephrine. You continue your CPR, right? And you might want to, secure intravenous access on your C circulation, particularly in situations where the patient is having cardiac failure. So secure intravenous access, give fluids. You might want to give warm fluids, particularly in situations where they are hypothermic. Give warm fluids. You go to your D disability, you want to do some basic investigations like your blood glucose level, because you have to ensure that the patient is euglycemic, right? You want to ensure that the patient is pneumothermic. So cover with one blanket, give first hair drive to the external surface. That's a form of your active external rewarming process. Or you can use warm intravenous fluid if available, right? Don't forget, you will have once you get to the hospital and you have access to supplemental oxygen, place the patient in supplemental oxygen. You can do your bag and max ventilation. If that is not working and you see that the patient is deteriorating, the airway is getting closed, the person has suffered pulmonary edema, you might want to do your endotracheal intubation and mechanically ventilate that patient, right? Um, so basically, that's all you do. Very easy. And in your secondary survey, you'll have done your focus examination, your CVS examination, your respiratory examination, and your CNS examination to see if there are other issues that you need to take care of. You will have ordered your chest X-ray to ascertain the level of the lung injury, because people that aspirate, people that get drowned, they can have acute respiratory distress syndrome, and you can see, the fluid within the lungs from the pulmonary edema from our chest X-ray. You can order a full, complete blood count. Most of the time, it's normal. You don't see anything. But on your arterial blood gas, you can see evidence of hypoxemia. You can see evidence of lactic acidosis from the glycolytic pathway that is being pursued, from the hypoxic insult, right? So just don't forget to remove their clothes, to rewarm them, correct the oxygen deficiencies, and you can take them off the acidosis from there. So moving on to high altitude sickness. So high altitude sickness is just a condition that occurs in people that are ascending through high altitude. That is just it. Especially when it's above 2,000 feet. Very easy. I want to remind us that this is a clinical diagnosis. Don't rely on any imaging. Three major stuffs to know. The first one is AMS, which is a acute mountain sickness. The second one is a high altitude pulmonary edema, and the third is a high altitude cerebral edema. So what happens in AMS? So as the individual is ascending through the mountain or going high altitude, maybe whatever is making the person go up. The higher we go, the lesser the PiO2, which is the partial pressure of oxygen in the air, in the atmosphere, right? And the fractional inspired, you know, um, oxygen content in the air. So the FiO2, the PiO2 both drops with ascent, right? And what is going to be the way the body is going to respond to this? So there's something called acclimatization. So the body will try to acclimatize to that situation by hyperventilating. So there's tachypnea. So, and when an individual hyperventilates, the person takes out CO2, right, leading to respiratory alkalosis at the end of the day. So, because the oxygen the person is even taking in that situation is not even enough to drive, oxidative phosphorylation. So the person might have a need to shift to glycolytic pathway, you know, and one of the products of glycolysis is what? The 2,3 BPG that we are all familiar with. So there's increased level of 2,3 BPG, and there is a shift in the oxygen distribution curve to the right, so that you can have more unloading of oxygen to the tissues for their own metabolic process. So that is the way the body acclimatized to high altitude. Now, but this hypoxia will have, caused some form of presentation. And the first is the acute mountain sickness. So what is going to happen? The hypoxia will just cause headaches, nausea, vomiting, fatigue, dizziness, lack of concentration. So a patient presents with sudden onset, fatigue, headaches, nausea, vomiting while ascending to the mountain, that is acute mountain sickness. So, you know, you might want to give supplemental oxygen most of the time. Supplemental oxygen might not be available. So the patient stops ascending or the patient descends, right? Patient descends, present to the hospital, place on supplemental oxygen, give NSAIDs, right, for the headaches. The patient might be fine. Sometimes you can have high altitude pulmonary edema because we know that the lungs is the only organ that responds to hypoxia by vasoconstriction. So what happens with the high ascension, the low PiO2, the low FiO2, the low oxygen concentration generally, the pulmonary vasculature undergoes vasoconstriction. There's pulmonary hypertension within that area, right? The pulmonary vessels are congested with a lot of, fluid because of the hypertension from the vasoconstriction. So there's some micro-inflammatory process that happens that lead to compromise of the vessel wall. So there's extravasation of fluid from the intravascular space into, the tissue surrounding the lungs, the alveolar sacs. So they leave the vessel into the tissue space, so causing pulmonary edema. So somebody ascends and the person starts presenting with cough, difficulty in breathing, shortness of breath. You did your physical examination, you can hear crackles. There's tachycardia, there's tachypnea, hypoxia. That is acute pulmonary edema from high altitude ascension that you are dealing with. So some of them can also present with high altitude cerebral edema, and these occur when the hypoxic insult causes a vasodilation of the brain vessels. You have a lot of blood rushing to the brain. There is a form of like an overload of the vasculature of the brain, leading to extravasation of fluid into the brain tissue, so causing cerebral edema. So what I just want us to pay attention to here with cerebral edema is that they present with altered sensorium plus ataxia. So somebody ascending and the person present with altered sensorium with ataxia, you think about high altitude cerebral edema, right? They are they are very fatigued, they are confused, they can be stuporous, they have ataxia, importantly, they can have visual disturbances, they can have problem with the bowel disturbance, bladder control problems. So, but the two major stuff you must always remember that will always be in the question stem is what? Ataxia and altered sensorium. And before I leave, I also must mention, with respect to the high altitude pulmonary edema, that you are going to get presentation very similar to pneumonia. But what would help you to separate from pneumonia is that in the question stem, you are going to get history of ascension to high altitude. And you will notice that the leukocytosis, which can happen here, is not going to be more than 14,000. So that is in keeping with high altitude pulmonary edema. Very, very important. So how do you treat? You stop the ascent or you descend. You give the person supplemental oxygen, right? NSAID for headaches, particularly in people with pulmonary edema, particularly in people with acute mountain sickness, rather. You can give some drugs like acetazolamide. So acetazolamide is a medication that inhibits carbonic anhydrase. Carbonic anhydrase is very essential to combine CO2 with water so that we can generate bicarbonate to reabsorb the bicarbonate, right? And you can secrete acid. So that means that if you don't have the activity of carbonic anhydrase, there's no way you can reabsorb bicarbonate into the blood, and there's no way you can secrete hydrogen from the blood into the urine. So it means you are going to have a situation of metabolic acidosis because you are not secreting acid into the urine and the acid are accumulating in the blood. So there's going to be a situation of metabolic acidosis. And this is good to acclimatize in RCT because the metabolic acidosis is going to activate the respiratory system to hyperventilate. So in an attempt to take in more oxygen, right, and take out more CO2. Very easy. So that's why you might want to consider acetazolamide in treating people with high altitude sickness. You give Dexa. Dexa is going to limit the edema. So, edema, cerebral edema majorly. So the glucocorticoid is going to reduce the edema. So that's why Dexa might be useful. And of course, you want to descend from the high altitude.